everyone. It's a pleasure to be here, and I have to say thank you to all of you who have hung in there for the final couple of talks. The title of my talk today is My Approach to Myelofibrosis Management. And I plan to outline some of the challenges in the management of patients with myelofibrosis and to discuss what I view as a contemporary approach to the treatment of MF in the JAK inhibitor era. So to put this talk in context, I'm going to start with a case of a 60-year-old gentleman who presented with a 6-month history of severe fatigue, weight loss, night sweats, and early satiety. His past medical history, interestingly, was significant for having had an MI 5 years prior and having had a diagnosis of ET for a little over 4 years, previously on hydroxyurea and subsequently managed with anagrelide. He'd had a JAK2 V617F mutation analysis done that was negative. His physical exam at the time of presentation to us was significant for splenomegaly, with his spleen being palpable 10 centimeters below the costal margin. His laboratory values were significant for, amongst other things, leukocytosis, mild anemia, thrombocytosis, 1% circulating blast. He also had an elevated LDH. His bone marrow slides were reviewed by our pathologists. These were the marrow slides from almost 5 years ago when he was diagnosed with ET. And those were felt by our pathologists to be in keeping with early primary myelofibrosis or prefibrotic MF. His bone marrow cytogenetic analysis showed a normal karyotype. So the patient at this point was surprised to be given a new diagnosis of myelofibrosis. He wondered what this meant. He wondered what we could do for him, and he wondered how he could be rid of the disease. So, as you've heard, myelofibrosis can present in a so-called prefibrotic phase, at which time it closely mimics ET, and patients tend to have a very high platelet count. Our patient had a platelet count approaching 1 million at the time of his original diagnosis. And in many patients, this then progresses to an overt fibrotic phase where you can see that the reticulum fibrosis becomes more apparent. By the time we were seeing the patient, the diagnosis of myelofibrosis was indisputable. So what does this mean in terms of prognosis? You've already heard that in patients with ET, the survival approaches that of age and sex-matched controls, whereas the survival in primary myelofibrosis, particularly overt MF, is much lower. So that was the first thing that we were able to tell this patient. And, patients are not living long because of various complications, including transformation to acute leukemia, as you've heard in the previous talk. But although the median survival in general of overt MF is in the 5 to 6 year range, we recognize that it's a clinically and molecularly heterogeneous disease and that an individualized treatment approach is necessary. This has led to the development of various risk stratification models. The most contemporary of those are the DIPSS and the DIPSS+. The DIPSS+ gives a more nuanced assessment of risk and includes, amongst other things, red cell transfusion need and factors in karyotypic abnormalities and thrombocytopenia. Using this, we could tell our patient that he had an intermediate 1 risk disease by both risk stratification systems, and he then wondered about the fact that he had heard that there was an FDA-approved drug that targeted the JAK mutation, but he had been told he was JAK2 negative and wondered what that meant. We generally, within our practice, as is customary for many other institutions, perform a next-generation sequencing panel on our patients. We generally do this in peripheral blood in our patients with myelofibrosis since they're inaspirable. Over 1,000 genes are sequenced primarily for research purposes, but of those, approximately 120 genes are clinically reported or clear certified, and those include the more than 50 genes known to be recurrently mutated in myeloid neoplasms. When we did his NGS panel, we found out that he had just one pathogenic variant, which was the calreticulin mutation. You've heard already that MF is molecularly complex. There are other mutations that co-occur with the JAK mutation, the calreticulin mutation, and the nipple mutation. And of course, these are the high-risk ones highlighted here, of which he had none of. Given the fact that he had just a CALR mutation without an ASXL1 mutation, we were able to inform him that in general we would expect him to have a relatively reasonable prognosis, in contrast to when you have a CALR co-occurring with an ASXL1 mutation. In this day and age, there's also an effort that's been led by Alejandro Vanucchi's group to get a more nuanced view of risk, which incorporates, besides the clinical variables shown, molecular risk factors to get a more precise, potentially more precise view of how patients may do over time. He had nothing additional based on the evaluation that we'd done. So by the MIPS score, he would also have been very low risk disease. So at this point, he wondered whether a JAK inhibitor would be of any value, given the fact that he did not have a JAK mutation. As you've heard in multiple other sessions, I'm sure yesterday, both the JAK2 mutation and the calreticulin mutation are now known to result in activated JAK-STAT signaling, and we know that virtually all patients who have myelofibrosis will have evidence of activation of that pathway. We also know that early on, and this was the early phase trial led by Dr. Vestovsek, had shown that very early on in treating these patients, whether they have a JAK2 mutation or not, you can show fairly rapid reduction of inflammatory cytokines in these patients, which likely mediate a lot of the symptoms, constitutional symptoms that they have. So he was prospectively HLA typed. He had no sibling matches, but had several potential unrelated donor matches. We started him on Rocksolid with prompt resolution of his splenomegaly and constitutional symptoms. We started at a dose of 10 milligrams twice a day, overlapping with Hydrea because he'd had significant myelosuppression, and myeloproliferation, significant thrombocytosis. We were concerned about the possibility of predisposition to thrombovascular events. He'd also had a prior MI. He's done fine, is on maximal doses of ruxolitinib now, and wants to know how long these improvements will last and what are the prospects for a cure. And to give him a sense of that, we refer to the 5-year follow-up data of the Confluent series, which have now been published, but which were originally presented at ASCO last year. And we see that patients who were originally randomized to ruxolitinib, in these patients, the median overall survival was not reached, and it was about 200 weeks for patients on the placebo arm, who, as you know, crossed over, virtually all crossed over at 24 weeks. So this is like a delayed RUX treatment arm. That's the good news. The not so good news is that the drug doesn't work forever for most, with the median duration of response being long, but still at approximately 3 years. And at 5 years, almost 3/4 of patients are off treatment for a variety of reasons. So this illustrates, of course, that there's more work to be done, and that new treatments are very necessary in this disease, and obviously you'll be hearing more of that in Dr. Vestovsek's talk. So is ruxolitinib appropriate for all patients with MF, even when they have higher risk disease? To try to address that, I'm presenting this other case of a 50-year-old gentleman who also presented with significant fatigue. His physical examination was significant for splenomegaly, with the spleen being palpable about 18 centimeters below the costal margin. His laboratory values were significant for leukocytosis, with a white count of over 25,000. He was significantly anemic when we first met him, with a hemoglobin of 8, which later dropped to 7, requiring transfusions. And his platelet count was within the normal range. We couldn't really find any significant other contributors to his anemia. He was hemolyzing some, but we attributed that largely to his splenomegaly. His bone marrow cytogenetic analysis revealed a normal karyotype, and his molecular analysis revealed that he was triple negative, so no evidence of the JAK2, CALR, or nipple, which, as you may recall from the mutation-enhanced IPSS or MIPS, is an independent predictor of poor risk. He was BCR-ABL negative, which I think is very important in these sorts of cases to still exclude. His bone marrow biopsy, again, was unequivocal for the diagnosis of primary myelofibrosis. And so based on his risk factors, the leukocytosis, the anemia, primarily, he was stratified as being intermediate 2 by the DIPSS, and with the transfusion burden or need for transfusions, he was high risk by the DIPSS plus. We thought about ruxolitinib for him, but in my practice, when patients are very anemic or needing transfusions, ruxolitinib is generally not my first choice if I can avoid it, because of the fact that, as many of you know, thrombocytopenia and anemia can occur with ruxolitinib, and typically patients will drop their hemoglobin by, almost 2 grams, with the NADA occurring at about 8 to 12 weeks as shown, and that translates in some to getting more red blood cell transfusions. So for this patient, the path that we took was to try to get him to a transplant as soon as we could. He was relatively young, 50 years old, no matched siblings for this one as well, but had many potential MUDs. And so he underwent a matched unrelated allogeneic stem cell transplant with achievement of CR, regression over time of his marrow fibrosis, resolution of his splenomegaly, normalization of his blood counts and transfusion independence, and achievement of full donor chimerism. 2 years after transplant, he developed a recurrence of leukocytosis with declining chimerism and underwent graduated donor lymphocyte infusions. His course was complicated by severe acute GVHD of the gut and skin that was fortunately steroid responsive. He's now approximately 3 years out from his transplant with a normal CBC, has recovered completely from his GVHD, which we don't always see, and is back to work. So this case illustrates the fact that allogeneic stem cell transplant can obviously cure some patients with myelofibrosis. We know in general that transplantation for low-risk disease is generally not recommended because those patients tend to have inferior survival post-transplant. Overall, you can see that obviously this procedure is not without its risks with both relapse and non-relapse causes of mortality. And so it's, patients do have to be carefully selected. So taking all that together, what's my approach to treatment of myelofibrosis in the JAK inhibitor era? I risk stratify patients by the DIPSS. I think it's important in the sense that it at least gives patients an idea of sometimes why we recommend, the things that we do. It also lets them know that this disease is not an indolent bone marrow disorder by and large. There will be patients who are low risk. There are not as many in my practice as I would like. The median survival by the DIPSS for those patients is not reached. And if they're asymptomatic, I tend to observe them. Clearly, we know this disease is progressive. If we had a drug or drugs that would significantly really alter the natural history of the disease with low toxicity, we might rethink some of those recommendations. And that's a setting where clinical trials are also needed. For intermediate 1-risk disease patients, again, because of the relatively long median survival, I tend to observe them. Although if they're really young and if they have a matched sibling donor, this deserves some discussion. My bias is to wait and not immediately move to transplanting those patients. If you're symptomatic or anemic, as many of our patients are, then you are obviously in need of immediate help. And various strategies are employed, with JAK inhibitors being at the helm. If you're anemic, I tend to stay away from those if you're very anemic and look for other strategies, including clinical trials, whenever we have trials that make sense. For higher risk patients, those who are younger and transplant eligible in particular, I refer early for transplant, and I employ JAK inhibitors at the same time. These strategies are not mutually exclusive. Clinical trials. So what are the unmet needs for myelofibrosis in the JAK inhibitor era? I have alluded to some of those over time. The core benefits are improvement in your spleen and in your symptoms. If you're cytopenic, this is particularly troublesome. The magnitude of the effects of this class of drugs on the natural history of the disease is still being debated, but it is clear that they do positively influence the disease in a good way. We just need more. Dr. Vestovsek is led the charge in that aspect in many ways, and will be speaking next. Thank you for your attention.